What's up, guys? It's Dr. Tim Jackson with another episode of the Boss Body Podcast. I'm breathing a little molecular hydrogen today, so don't mind me. But we have another very special guest. Well, she's special because of her knowledge base, and also she's a fellow Wake Forest Demon Deacon.
While I make every effort to broadcast correct information, I'm also still learning. I will double check all my facts, but realize that healthcare is a constantly changing science and art. One doctor or healthcare provider may have a different way of doing things from another. I welcome any comments, suggestions, or correction of errors. I take no money from supplement or device companies. By listening to this podcast or reading this blog, you agree not to use this podcast or blog as medical advice or to treat any medical condition in either yourself or others, including but not limited to patients that you are treating. Consult your healthcare provider for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast or the website. Under no circumstances shall any guests or contributors to the podcast or blog or any employees, associates, or affiliates of the Boss Body Podcast be responsible for damages arising from use of the podcast or the blog. This blog or podcast should not be used in any legal capacity whatsoever, including but not limited to establishing the standard of care in a legal sense or as a basis for expert witness testimony. No guarantee is given regarding the accuracy of any statements or opinions made on the podcast or the blog.
Welcome to the show, Dr. Michelle Pearlman.
Thank you for having me.
Absolutely. So you have a pretty unique background in terms of your training was, very conventional, but then you realized that, what you were doing as a gastroenterologist and internist wasn't necessarily addressing root causes, and the time you spent with patients wasn't necessarily optimized. Can you tell us a little bit about that?
Yeah, it's interesting because so much of the time don't mind the tape that's keeping the organs in here. So
Okay.
much of the time we think of the mind or the brain and the body as two separate things. And the reality is they are one and the same. Whatever is going on up here affects everything down below and vice versa. And as a gastroenterologist, many of our symptoms are related to other things outside of the abdominal cavity, whether it's stress, anxiety, happiness, sadness, whatever that emotion is, people often feel it in their gut. So as a gastroenterologist, I trained 3 years learning how to do endoscopies and certain biopsies and colonoscopies and fancy maneuvers. And that's obviously there's a huge role in that. And I'm very blessed to have that training. For me, I thought I was really adding more value in the other things like outside of the operating room, right? Having those nuanced discussions for the rest of the time that they were spending at home and traveling and with their family and what people were doing on a daily basis that were affecting their health.
Absolutely. And so what got you into nutrition and exercise? Because obviously, you've heard the stat that the traditional allopathic doctor dies 10 years before their average patient. So, when in high school, when I was a senior, we had to do like a week in the career we thought we were going to go into. So I went to a hospital about an hour and a half away and worked in the emergency room under one of the attendings. But there was a surgeon, a general surgeon, who would literally tell his nurses to hold the clamp. He would go outside and smoke and then come back in, re-sterilize, and then go back in the OR. And so, I'm curious, what got you into weight training and nutrition?
So that was my stress release. I used to go to the gym starting, I remember in middle school, every day in the afternoon. That was the way I kind of dealt with stress. I became obsessed with it and I continued those habits in undergrad. And I was actually a personal trainer on the side when I was an undergrad. I went to the University of Miami. And I remember one day, one of my clients said, "Oh, I'm going to go to this bodybuilding show. It seems like a cool event to go to." And for some reason, I looked at the promo and I said, "Yeah, I'll go too. Hell, why don't I just compete?" So
Right.
I put my body through the ringer and I ended up prepping myself for a show within a 6 week span. Now, I've learned through myself healthy ways to do it and unhealthy ways. And so every day for 6 weeks, I was doing 2 hours of cardio every single day and really cut out all carbs. And so I think for me, like my stress release was going to the gym, but I've also been on all these yo-yo diets and kind of bodybuilding type plans where it wreaks havoc on your metabolic rate. And so I went through it myself. And then throughout medical school, I would eat sweets when I was stressed or anxious or I took a board exam. And the weirdest thing, I'd wake up the next day and have neck pain. I thought I was developing like fibromyalgia. And I said, well, this is strange. It must be tied to my food. So I felt it on a personal level where when I ate crap, I felt like crap. I was tired of feeling that way. And then when I ate better, I just felt so much better. And I wanted my patients to feel that way too.
Awesome. And so obviously the schedule of a resident and medical student, and then when you're in private practice, it's difficult to get those workouts in. So do you have any tips for men and women listening who are busy professionals? Some might be doctors in training or residents. Do you have any tips for them?
I think one of the things that's hard to do early on in training is setting boundaries. I mean, I would say if you were to ask me like what is my what sort of superhero would I be as what is my superpower? I am very good at setting boundaries and I was always making self-care a priority. I didn't care what else was going on. Obviously, if there was an emergency or I was on call and I had to go in, I obviously took care of it. But I was also very good at setting boundaries for other people, saying no to things and taking that time. So for me, no one's bothering me at 4 in the morning or 4:30 in the morning. So that is my time. I get up at 4:15. I'm at the gym by, usually 5 o'clock. I get my workout in and I go to work because I know patients and whatnot, no one's going to be calling me between the hours of 4 and 7. So you got to
Yeah,
figure out like what time is going to be feasible. Everyone knows themselves better than anyone else. I know I'm exhausted after work. So the reality is if I say I'm going to go to the gym at 7 p.m., it's not going to happen. We got to figure out what is our schedule like? When do we have energy and carving out the time when it's going to be easiest to do?
absolutely. Yeah, I saw on your Instagram some crazy workout times. Like you would say, "Oh, I got up at 5 a.m. or something, and I'm the only one in the gym." And I'm like, "Okay, I love working out, but I'm not getting up at 5 a.m." But yeah, if that's that's when you can work out, work out. Me, I'm more of a like mid-afternoon guy.
Yeah.
But in terms of, so in your clinic, you guys see everyone from weight loss patients to hormone replacement. You do hormone replacement, correct?
Yeah, exactly. So I'm a gastroenterologist and I am also certified in obesity medicine. So most of the patients that see me have metabolic syndrome, whether it's prediabetes or just insulin resistance, high cholesterol, high triglycerides, high visceral fat, sleep apnea, kind of the all the typical things that we see in healthcare. Many of my patients have those conditions. So many of them are seeking me because they want to lose weight. But I'm really not one of like, I wouldn't call myself a weight loss clinic because people are
Okay.
so focused on that ideal body weight that doesn't actually exist. I'm trying to improve overall cardiometabolic health. And as a result, people are going to lose weight. But my goal is to focus on losing fat and maintaining muscle because, as you know, muscle is medicine. So it's less about selling weight loss, more about improving one's cardiometabolic health. And then I do some sports nutrition. So people training for half marathons or marathons or want to just improve their endurance or strength, I do that as well, even if people aren't trying to lose weight per se.
Okay, awesome. And in terms of, so the past 2 to 3 years, GLP-1s have exploded in popularity. And, some people love them, some people are adamantly opposed. But I feel like, there's a significant number of providers who are not necessarily using them correctly. It's just writing the script, and there's no, again, like you mentioned, the 10 to 15-minute office visit. You can't talk to them about, okay, essential amino acids are going to be a good idea to preserve lean muscle so you don't go into a hypermetabolic state. We don't want to cause hormonal derangement, all those things. Can you talk about the correct way to use the GLP-1s?
Yeah, I got my little platter of pens here. I think
Awesome.
people are confused, right? Because everyone hears Ozempic and they assume that all these injectable medications are the same and they are a little bit confused as to the different sort of FDA indications. So semaglutide is either Ozempic for diabetics, or you have Wegovy, which is for weight loss in non-diabetics. And then the newer medication that came out earlier this year is tirzepatide. So that's Zepbound for non-diabetics and Mounjaro for diabetics. So those are the typical medications that I use every day. When I was at my prior job at a university, that's when Ozempic and Wegovy first came out. So I really wasn't delving too much into it because I only had the access of seeing patients once every, 3 to 6 months. So with these medications, it makes that sort of health system very hard to use these medications properly. which was one
Right.
of the reasons why I honestly left and kind of started my own practice.
Sure.
Is I saw the wave of these second generation weight loss medications, and I knew if people were not being supervised and followed up in a timely manner, we could sometimes do more harm than good when it comes to muscle wasting.
Right, absolutely. And in terms of side effects, you hear about the risk for
Mhm.
pancreatitis. You know, I've seen people post on social media the Mounjaro or Wegovy face. Can you comment on the risk of side effects?
Yeah, it's interesting. I mean, the press and the media, they want, a sexy story, right? So they're going to talk about the really good stories and the really bad stories. They tend to skip over the majority of people. So these hormones, they are gut hormones. They're released from our small intestine after we eat, and then they send signals back to our brain and help us feel full. They work on the satiety and reward centers, and they also delay our stomach emptying. So if we go back into how the mechanism works, most of the side effects are GI related because they work on the gut. So if people eat too much, they eat too fast, they eat too late, or they eat really fatty foods, fat out of all the macronutrients is going to delay gastric emptying the most. Then people will tend to have GI side effects, which often are heartburn, regurgitation, nausea, sometimes diarrhea, sometimes constipation. So most of them are GI related. Now, pancreatitis is a potential side effect, but a lot of medications can cause pancreatitis. Ibuprofen can cause pancreatitis, tobacco, alcohol, statins can cause pancreatitis. It's a big side effect, it's a bad side effect. And if it happens, we have to stop the medication. But just because someone has abdominal pain or nausea, we should not be labeling them with pancreatitis unless we have imaging to show that symptoms that correlate and a lab that correlates with that as well.
Right. And then your patients and clients, what percentage would you say of the people, like let's say they're on them for 6 months? I don't know
Mhm.
what the typical time frame is, but when they go off, what percentage of people have rebound weight gain?
Yeah, so these medications were developed for long-term use. So if you look at the data and then you keep someone on a placebo injection versus you keep them on the medication. When you put them on placebo, people are gaining, two-thirds of the weight back. And the problem is the weight they're gaining back is not the muscle they lost, it's fat.
Right.
So their body composition could end up being actually worse than when they started. That's not a problem with the medication per se. That's what happens with any weight loss program, whether it's diet and exercise alone, medication, endobariatrics, or bariatrics, the body changes. When we get to a lower weight, a lot of things happen. One is what's called metabolic adaptation. Our muscles become more efficient. We burn less calories doing the same exercise. And if we lose muscle, then our metabolic rate drops. So the plan to lose the weight, whichever method you choose, is often going to have to change in the maintenance mode, right? What most people tend to forget is the hardest part of weight loss is not losing the weight. It's maintaining the weight loss as life happens and our body changes, particularly for women going through menopause. Everything changes during menopause.
Yeah. And I was curious, do patients report that it's difficult to follow through? So if they're working out or they start working out, is it difficult? I know if I don't have enough calories, I go to the gym, I just feel kind of flat. Do people
Mhm.
report, decreased strength because of the caloric deficit?
Well, so that's the biggest thing is I don't have people count their calories. I actually have them count their protein. That's what I want people to make sure they're getting enough. Because the issue is that if I just tell someone, okay, we're going to start the injection, but cut your calories to 10,000 a day, if they're just eating like slices of bread or something and crackers because they're not hungry, they're going to feel weak. They're going to lose muscle. They
Right.
may lose weight and they be thrilled by the number on the scale, but they're going to actually be frail and malnourished. So when I have
Right.
people focus on the protein and make sure they're getting adequate protein, they feel much better. And that's the only macronutrient our body actually needs to survive. And that's the critical macronutrient we need to preserve and gain lean muscle mass.
Right. And in terms of supplementation, do you have any
Mhm.
go-to supplements that you tend to recommend for most patients who are going on the GLP-1s?
Yeah, so it depends on the person. I always get kind of some baseline labs. I'll always check like B12 and folate and vitamin D. And then if someone has, let's say, celiac or other things, I'll check their iron and other things depending on the person. So I always like to get a baseline. Even if someone's obese, they're very high risk for being malnourished.
Right.
So vitamin deficiencies are very common. Our produce and our food nowadays, as you know, is not the quality we had 50 to 100
Right.
years ago. So even if people eat healthy, they can still have nutrient deficiencies. Many people can benefit from a B12 supplement, even if they're not vegan. So even if I
Right.
have a patient who has like a normal level, but it's on the lower end, I'll often put them on B12. A lot of people, even in South Florida, need vitamin D. So I use a vitamin D supplement that has K2 in it to help with calcium absorption. And then otherwise, it just depends on the person, depending on their deficiencies and if they're able to get adequate nutrients through their diet. But I typically am not recommending like, a multivitamin per se.
Right.
As like a pre-workout, or like an intra-workout, I'm a big fan of creatine. So I have, a certain brand that I like to use, like a creatine isolate formulation that people just add like 5 grams of water with their workouts. But I keep it pretty simple. I use medications when I think it's necessary, but I try not to overwhelm people because sometimes when we give them 5 or 10 things to do, they don't end up using any of them.
Right. Yeah. Compliance, I think, is the name of the game. And you mentioned creatine. So I think most people are under the impression that creatine is only for building muscle. But if you look at most of the studies, it's on prevention of neurodegenerative conditions.
Mhm.
And so, but I was reading recently, I haven't had time to look it up, but an association, not necessarily correlation, between creatine and cancer. This was the first I'd heard of it. Do you have any knowledge on that?
I don't, but I've been looking at a lot of studies looking at Alzheimer's dementia and just neurocognitive function. And that's reason enough in my book to save our
Yeah.
brain.
Yeah, exactly. I mean, if you can improve the mitochondria, and creatine definitely does, with ATP, then you're going to preserve cognitive function. So the more we can do, and then you're also going to feel stronger and,
Mhm.
less likely to have falls, hip fractures, and then you're going to end up in the hospital with pneumonia. So the more we can prevent sarcopenia and increase strength gains, I think, that's a great thing.
Yeah.
Let's talk about the gut microbiome. And so, more and more gastroenterologists are paying attention to it. I mean, I remember back in like 2011, I had a little something going on. I went in and the guy, he wanted to give me an antibiotic. And I said, well, I don't want to do that. And he said, why? And I said, well, I was overprescribed antibiotics as a child. And I mentioned the microbiome. And he's like, what? And I was like, all the beneficial commensal bacteria. And he's like, what? Um, but I mean, I think you pay attention to the gut microbiome and the importance of, prebiotics feeding the bacteria that are there, and then in certain situations, probiotics. Do you incorporate those?
Yeah, absolutely. I think, we're learning more and more about the microbiome. It's an organ in itself. We have trillions of bacteria. We have more, bacterial species in our body than we do actual human cells. I mean, it's absolutely phenomenal. We can't eat perfectly. We can't live perfect lives, but the reality is, we have all these really special bacteria that are keeping us alive. And it's the things we do on a daily basis constantly that affect whether or not they're going to protect us because our gut is our largest immune organ. The lining of our gut, the GI associated lymphoid tissue, the microbiome, all these things, the enteric nervous system, we have to protect it. And I think during COVID, people saw the importance of, protecting our immune system. And so I think people are learning more about it. They're more interested in learning about it. But then you also have a whole marketplace that's bringing in a lot of supplements and other things that may or may not be beneficial, right? So when
Right.
we hear these terms like prebiotic, probiotic, postbiotic, many people are confused as to what those actually mean. Prebiotic is basically dietary fiber. So simple things like chickpeas or nuts, hemp seeds, edamame. You can see I have all these things at the
Yeah.
office ready to go. Our patients leave here with a goodie bag so they know what to order on Amazon. They can try things out. And we just have to make healthier options very accessible. So the bacteria love dietary fiber. So that's number one. People can take, fiber supplements like Metamucil or Citracel, but if we can get it from our food, that's really the best way to do it. And so for most people, we need to get 25 to 35 grams of dietary fiber a day. Most people get probably a third of that. So dietary fiber is very important. And then probiotics, I don't know what your stance is on that. I think if people again can get it from food, that's ideal. The whole probiotic supplement industry is all unregulated. So a lot of times the probiotics that are sold are just the ones that are easy to grow.
Yeah.
But we don't really know if they're viable or not. So unless they're,
Right.
made in a manufacturing plant where they're actually testing not the colony forming units, but like the viable units,
Right.
those I trust a little bit more. but it's obviously a huge marketplace, a huge moneymaker. But again, if people can get it from food, whether it's, kombucha, kimchi, Greek yogurt, sauerkraut, I'm a big fan of that as well.
Yeah, I mean, I think with probiotics back in the day when I started taking them, I thought that you take them, they colonize the gut microbiome, and they just reside happily ever after. But we now know, the effects are transient. They're interacting with the dendritic cells, the gall, the malt. But the ones that I do really like are the spore-based probiotic. You can reduce lipopolysaccharide levels up to 46%. In a study they did at the University of North Texas, they had undergrad students just continue eating their junk food diet, and they gave them a spore-based probiotic, and so they saw a 46% reduction, and that's without any dietary change. So now they produce 12 antimicrobial peptides. You don't want to take them indefinitely because you can kill off commensal bacteria and reduce the alpha diversity. But I think the spore-based are good. And I just interviewed a guy named Joel Green who authored the Immunity Code, which is all about the gut microbiome, feeding the beneficial bacteria. He's big on green bananas, resistant starch to feed Akkermansia, bifidobacteria. And I think the prebiotics are probably more important than the probiotics, in my opinion. It's like you said. Number one, one thing I didn't think about until about 7 or 8 years ago is if you have to refrigerate something, well, when you take it, what's that going to do when it's in, your body in terms of the temperature difference? So
Mhm.
that's why I like the spore base, because you don't have to refrigerate them and you use them for a finite period of time. But I think overall, people with the best gut microbiomes I've seen are people who meditate. Because I've seen people who are doing prebiotics, probiotics, all these fancy gut supplements. And then I look at their tests and they see improvements, but it's marginal. And then I see people who aren't necessarily taking prebiotics, but they're meditating, their central nervous system, autonomic nervous system is balanced. And so, they do a lot better in terms of the alpha diversity in the gut microbiome.
Well, you bring up a really good point. Like stress legitimately kills people.
Yeah.
I used to laugh about that. Like I didn't actually
Yeah.
think it would happen. I remember specifically one patient at the hospital when I was in actually in attending a couple years ago said that like when he was divorcing his wife at the time, the stress gave him ulcers. And I was like, there's no way, like that could not happen. But stress legitimately kills people.
Yeah.
And it's like we work so hard our entire life. And so many of my patients, when they retire, they think it's going to be easy. They have the financial freedom. They want to travel the world and spend time with their family. And it's decades worth of terrible behavior. Now they can't travel. They're weak.
Right.
They have to go to doctor's appointments upon doctor's appointments, and they miss the opportunity to really take care of themselves. So,
Yeah.
our goal, and I think probably one of the reasons for your podcast is to educate, people of all ages to say, what are the changes we can make starting today so that those, I don't know if you listen to like Peter Attia, I love his
Uh-huh.
podcast, but the last 10 years of our life, that marginal decade, for most people, it's a brutal one. But what if those 10 years could be some of the most beautiful years of our life? It can
Right.
happen. Aging doesn't have to be painful, but it's again the
Right.
decisions we make tomorrow, the next day that will impact that.
Absolutely. And talk to us about SIBO, small intestinal bacterial overgrowth. There's is it Dr. Pimental, who used to be at Johns Hopkins, Mark Pimental. They have an integrative gastroenterology center at Johns Hopkins. But I didn't know if you do like the hydrogen breath test, the methane breath test, and what your thoughts are on those.
Yeah, so SIBO is pretty common actually. It's small intestinal bacterial overgrowth. We have more bacteria in our colon, and for many reasons, some of that bacteria can start to get into the small intestine. The reason why that's an issue is that can interfere with absorption of certain nutrients, and it can cause common symptoms like diarrhea or bloating, or people can have constipation. So it's a pretty common issue. Reasons that would increase your risk actually are like antacids, like PPIs or proton pump inhibitors, any sort of abdominal surgery, especially if you've had like a partial colon or intestinal resection where they've cut out your ileocecal valve. That's kind of the valve between your small and large intestine. So those would be some risk factors there. Any sort of dysmotility problem. So whether it's like
Right.
Ehlers-Danlos or any sort of problem that causes dysmotility, the bowel can cause it, and just chronic constipation, or
Right.
pelvic floor dysfunction can increase the risk. So again, common symptoms are very nonspecific. It could be unintentional weight loss, constipation, diarrhea, bloating are the typical ones. Um, And how do we test for it? We tend to do breath testing. It's usually in like a center, but there's also at-home studies, although I haven't tried those, but it's pretty common. Now, the caveat to that is, well, how do we knock down the bacterial load? In
Right.
conventional medicine, we give antibiotics, right? And many of those antibiotics, like Augmentin, can cause GI symptoms. So the one
Right.
that I tend to use would be something like rifaximin, which is not a systemic antibiotic. It just knocks down the bacterial load inside of the intestine. And so
Okay.
that will often take care of it. If you have a certain type of SIBO, then you want to add in, I think it's like erythromycin, or I believe, I haven't treated it in a while. So there's different methods. But the reality is, if it's a structural issue, then it's likely to come back, right? You're not giving
Right.
someone back their ileocecal valve. You're not changing the dysmotility disorder. So you want to get rid of risk factors. You want to treat the constipation, get someone pelvic
Right.
floor, pelvic therapy. But if we're not treating the underlying cause, right, the root cause, then
Right.
SIBO often comes back. And then it's like, well, how long are you going to keep putting someone on antibiotics? It can be a
Right.
problem.
How do you feel about Xifaxan?
Yeah, so that's rifaximin. So that's the same
Oh, okay.
medication. Yeah,
That's the other
yeah,
name. Okay.
yeah,
Gotcha. Yeah,
yeah,
I know because it tends to, I know it's a little pricey, but one thing I learned a few years ago is
yeah.
that Life Extension actually has a pharmacy, and their prices are very reasonable, and you can have the
Yeah.
prescription facts there. But there are herbal protocols, but if you're not addressing why is the bacteria translocating from the colon into the small intestines, and it's going to recur. And I
Mhm.
see a lot of people with vagus nerve dysfunction. So I don't have it up here, but I have a little vagus nerve stimulator I do right here a few times a day, and that really helps. I can tell, in terms of my bowel health. And the other thing I have people do are body weight squats below parallel,
Mhm.
because I learned this from Paul Check. I don't know if you're familiar with him, but he's a holistic health guy, and he says we're the only organisms on Earth that have to push poop uphill against gravity. So the right femur is supposed to push fecal matter up the ascending colon. And so, that alone may not change things, but in combination with hydration, movement, vagus nerve stimulation, prebiotics, stress reduction, I think can really move the
Mhm.
needle.
Yeah, I mean, it's crazy. The American lifestyle is really promoting sickness. We're
Yeah.
sitting at a desk all day, we're not moving. I remember at my prior job, we weren't even allowed to have water bottles in the workroom where patients weren't even in there. So it's like, as
Wow.
healthcare providers that are working long hours and we're in and out seeing patients, we literally were not able to drink water. We could go to the break room, but if you have 20 patients on your schedule, when are you going to get to do that? So I probably urinated like once during the entire day.
Wow.
That can't be good for the kidneys or bladder,
No.
but it is all in line with what you're saying, where healthcare providers, our task is to take care of everyone else. And oftentimes our own self-care is put on the back burner. And we're oftentimes felt guilty about prioritizing our health.
Yeah, I feel like I think back when I finished undergrad, Yale, their surgery program got in trouble for overworking the maximum allowable hours for the surgery residents. Now, I mean, they're probably still doing it, just, under the radar. But I just don't see how that's serving either the patients or the doctors. Because I had Dr. Rob Downey, who's an MD in Alaska, on, and he said when he was in med school, the thought was if you're not falling asleep at the nurse's station at 1 or 2 a.m., then you don't really want to be a doctor. But it's actually the opposite. Like if you're not taking care of yourself, how can you pour from an empty cup?
I know. I mean, if you look at like how we function after a 28-hour call, we may as well be drunk. I mean, that's the
Yeah.
extent of like how our brain is working. I just remember, yeah, I remember those days. I can't believe I survived it, to be honest with you. I think it's gotten better, hopefully, with all these regulations. But then, there's a catch 22. If now all it is just shift work where you're having 8-hour shifts and now you have a lot of turnover between the healthcare providers, then things can get lost in translation between those handoffs. So I think
Yeah.
we still have a long ways to go.
Yeah, absolutely. So what else do you guys, I know you practice with your sister. Did she go to Wake Forest?
For part of her training, she actually did. So we kind of
Oh,
followed
really?
each other around a little bit. So I did my undergrad at University of Miami. Then I was at Wake Forest. Then I figured if I was going to be on call for long hours, I'd love to do that in San Diego. So I did internal medicine residency at UCSD. And then I did my gastroenterology and hepatology fellowship at UT Southwestern in Dallas. And then my sister actually started her medical school at Baylor in Houston for medical school. Then she went to UPenn for urology, and then she did a reconstructive and men's health fellowship actually at Wake Forest way after I was gone. So,
Oh, wow.
and then she directed the men's health center at the University of Iowa, as a
Oh,
woman.
wow.
And a lot of people would ask her, what in the world is a woman doing only seeing men? And her
Yeah.
her response is always, I went into the field so I could better understand men. And I still don't understand men.
Yeah, that's funny that you say that. I had Dr. Molly Maloof. She's an MD, doctor of sex,
Uh-huh.
drugs, and rock and roll. But she tells the story. Somehow she ended up getting someone's testosterone gel on her forearm one day. And she said about an hour later, she was like literally looking for any guy that she could, have intercourse with. And she's like, that at that moment, I realized that guys aren't, bad, like morally, it's physiological, like, it's an evolutionary drive. And so, that really changed the way she thought about treating people.
Yeah. So it's interesting because, I'm a gastroenterologist and I had no training in menopause or hormones. I mean, absolutely zilch. And my sister, she was trained as a surgeon. So urologists are really not trained in hormones. They are in the operating room. So I think
Right.
when people are looking for, help with their hormones and optimization, they think, okay, is it internal medicine doctor? Is it an endocrinologist? Is it a urologist? Or would it be a gynecologist for a woman? The reality is none of these specialties are getting training in
Right.
andropause or menopause unless people are
Right.
specifically looking out for it. So my sister, she was like considered the expert in Iowa and she never really had much experience. So she became the expert in Iowa. And
Right.
she's, in our practice now, she's helping all these men improve their sexual, improving their sexual life and their libido and their erections. And all these men are saying, I need you to help my wife. You're helping me. My
Yeah.
wife wants nothing to do with me. I need you to help her.
Right.
So my sister and I are actually in the midst of getting certified as certified menopause providers. So she's going to be doing the sexual wellness, libido, and the genital urinary syndrome of menopause for women. And I'll be tackling more of the systemic hormones because most of the women I see are perimenopausal or postmenopause. They are developing all these chronic conditions that happen when they reach menopause and they're gaining weight and particularly visceral fat. So we can use these GLP-1s to help them lose weight. But if I'm not addressing the underlying estrogen deficiency, then I'm not
Right.
using all the tools in the toolbox.
Yeah, absolutely. And I'm curious, do you ladies do the Gainswave machine?
So my sister has the another shockwave machine.
Okay.
It's the Stork, and so she uses
Okay.
that for erectile dysfunction.
Okay. Yeah, I've heard, I've never used it, but I've heard great things about it, along with peptides. And I've heard some docs even do exosomes into the
Hmm.
penis,
Hmm.
and the O shot, P shots, all those things. But I think, working on hormones and systemic inflammation will go a long ways towards improving libido, and overall health, right?
Yeah. Yeah. And I think, there's a lot of medications out there. It's a really cool time to be in the space of weight loss and like sexual wellness. I think they're obviously, um, huge markets. But it's interesting because typical health programs are not teaching you sexual wellness, right? They're
Right.
teaching you about kidney stones and urinary tract infections. They're
Right.
not really promoting like the sexual wellness, even though that's a huge part of many people's lives when it comes to their quality of life. And then same
Right.
thing for the weight management. We're learning how to do endoscopies and colonoscopies and how to give antibiotics for diverticulitis. But if we're not addressing the underlying issue, which is weight gain as we get older and the loss of muscle mass, throwing antibiotics at someone for, chronic UTIs is not going to help
Right.
them in the long term. So I think with all the information we have, I think we can do better. I think it takes a lot of creativity and thinking outside the box. And it requires sometimes healthcare providers to take a leap and honestly try to do their own thing because the healthcare system is a box, the system is broken, and it's really hard to change that culture. And I don't think it's changing anytime soon.
Yeah, it seems like some people either do what you and your sister did and, start to learn a better way, while still using some traditional treatments and therapies. But other doctors and providers will just dig their heels in and just deny that, hormones are important. I had Dr. Cassie Smith, who's an endocrinologist in Oklahoma City, on the show. And she said, I did everything I was taught in medical school, residency, and fellowship. People came back, not only were they not getting better, they were getting worse. And every 6 to 12 months, we were adding a new medication. So she left her endocrinology group and she was renting space in the same building. Well, she started doing integrative medicine and getting results they could never get. So then they wouldn't renew her lease. So that's, how the system works, unfortunately. But
Yeah.
I mean, I think it takes a really mature person to say, okay, I've done all this training. I may not have gotten, what I need to be able to best serve people. So I'm going to learn, some additional skills.
Mhm. And yeah, we just wanted to practice medicine the way we wanted to. And I
Right.
just, in my practice, I couldn't see 20 or 25 patients a day and then say, okay, I'm going to start you on Ozempic. I'll see you back in 6 months because I knew what was going to happen. And with these medications, like I see patients on a monthly basis and I titrate. So when we talk about the safety and how to do it properly,
Mhm.
many people will come to me and say, like, I want you to shut down my appetite. Okay, I can shut down anyone's appetite if I jack up the dose high enough, right? And they'll lose
Mhm.
weight. But I'm looking 10, 20, 30, 40 years from now. How are they going to maintain their overall health, right? Not just six
Right.
months from now. So I actually titrate the dose based on their muscle mass. So I have a Seika bioimpedance scale in my clinic. It's a medical grade scale. I get them on every month if they come into clinic. And that's how I adjust it. So I understand how much protein are they eating? What is their fat loss? What is their muscle looking like? Are they able to eat enough protein? Are they feeling satisfied with their meals? Do we need to increase the dose because they're
Right.
eating smaller meals and they're not satisfied? And so I adjust it based on that. And I tell people the goal is not to create a food aversion. The goal is not to shut down your appetite. I don't want you to have to force feed yourself to get your protein. The goal of these medication is you eat your protein, you eat your veggies, maybe you have a little bit of a starch and you feel satisfied and we get rid
Right.
of the food noise in between meals. But I want people to eat. I want people to eat
Mhm.
protein and I want them to feel well. The goal of the medication is not for you to feel sick in order to
Right.
lose weight. Yeah.
Yeah, I can't possibly imagine anyone feeling well with very little nutrient intake. It just doesn't seem like it would be a good idea,
Yeah.
physiologically, biochemically, or just from a common sense standpoint, really.
Yeah. And so I think a lot of practices, nutrition is not obviously a big part of our curriculum in most
Right.
curriculums. And with these medications, I've heard people say, oh, we don't need to talk about nutrition as much because the medication makes it easier. People will just eat less. And I don't agree with that. We should be talking about nutrition and strength training on day one because with or without medication, people need to understand how to eat for their body, eat to feel, eat well to feel well, protect their gut microbiome. The goal is
Right.
not to use the medication so you still eat crap and just less of it. Maybe in the beginning, as people are trying it out, you need to do a stepwise progression. The reality
Right.
is, if people want to be successful and do it safely, they got to eat better quality food and they have to be willing to do that. So just
Right.
because someone makes an appointment with me and I'm an out of network provider and they're paying my professional fee, by no means does that mean they're getting a script. I need to make sure they're a candidate and they're willing to put in the work so they're going to be successful.
Absolutely. So it sounds like, you're definitely a lifelong learner, you and your sister both. But what's something you or you and your sister know today that you wish you would have known, say 10 years ago or 8 years ago?
Muscle is medicine. Muscle is medicine. I mean, I was a bodybuilder, like I knew it was important. I didn't truly understand the impact of movement more so than nutrition, actually. Like, I don't think you'll find a single article out there that said exercise is bad for us. When it comes to
Right.
nutrition literature, you're going to see things that are all over the map and very contradictory. But when it comes to exercise, improving our VO2 max, increasing our muscle mass is so important, even when it comes to just glucose regulation. Muscle
Hmm.
is a glucose sink. And as
Right.
we get older, we lose muscle. So today is the day. It's never going to be any easier than right this second to gain muscle.
Right.
And so I think a lot of women out there who are going through perimenopause, they don't realize that 10 years from now, it's going to be about 20 times harder to gain muscle. So we have to focus on muscle. It's less of a focus on losing weight. The big issue is the lack of muscle in people and obviously just excessive fat, but it's focusing on building muscle. And then ultimately that will improve everything else. So I wish I truly understood the importance of muscle, not just for myself, but like on a physiologic level the impact
Sure.
it has on every organ system.
Yeah, you got to upregulate those GLUT4 receptors, right? That's where the magic happens. It's the secret sauce.
Yep. And I think also just the importance of sleep. I
Yeah.
didn't
Oh, yeah.
realize the importance of sleep until I was road cycling. I had a bad wrist fracture. I had surgery and I couldn't sleep for 2 months. My personality changed. I
Yeah.
became a completely different person. So now I have a lot more empathy for people who have like chronic pain who can't sleep because it changes you.
Yeah.
And so now, every patient that comes into clinic, I'm screening them for sleep apnea because as much as they say, oh, I get 7 hours of sleep and I snore and my partner says I sometimes stop breathing, but I feel fine. I just drink a bunch of coffee. It's like I go into the reason why quality sleep is important, and our
Yeah.
day starts the night before and sleep, just like muscle, affects every single organ in our body.
Yeah, I have an oral appliance that brings my mandible down and forward. And me, it's from being stocky relative to my height.
Mhm.
And so I think there's a misconception out there that, oh, you have to be obese to have sleep apnea, but no. You can have a tongue tie issue, you can have decreased maxillary width, paranasal sinuses are congested, all those things. And that's going to impact, your libido, sexual dysfunction, risk for neurodegeneration. And so I think that's absolutely critical, especially you're not going to lose weight if you're not getting deep sleep, right?
Oh yeah, and a lot of people will say, "Oh, but when I lose weight, then I won't have sleep apnea." And I'm like, "But you don't understand. It's going to be a lot more challenging to lose weight when you have
Right,
undiagnosed and untreated sleep apnea." So
right.
people say all the time the CPAP machine isn't sexy, neither is snoring, neither is not breathing in the middle of the night and not getting your brain oxygen.
Or
So
dying.
sometimes people, exactly. So it's people just need to understand why. It's all about the messaging. If you tell a 20-year-old kid, try not to gain weight because you may develop heart disease or sleep apnea when you're 60, he's not going to care. But if you tell him, oh, by the way, like vaping has a lot of nicotine, nicotine is a vasoconstrictor, it's going to affect your erections, you better believe that 20-year-old is going to think next time, he grabs a vape pen. So I think it's our
Absolutely.
job as healthcare providers to figure out who's our audience, who are we speaking to, what matters to them, and then reword the way that we say what we say so it resonates.
Absolutely. Well, thank you so much for the work that you and your sister are doing. We're going to put up all your social media links and links to your website. And if people are interested in becoming a patient, they can reach out to your staff via the website, correct?
Absolutely. So primeinstitute.us, you just scan the barcode or submit an inquiry and we'll give them a call within 24 hours.
Okay, awesome. Well, thanks so much, Dr. Pearlman.